Program by introducing Dr. Sarah Ronis. Dr. Ronis is an academic pediatrician and health services researcher dedicated to improving systems of care for low-income families and their children. She's the director of the Center for Child Health Policy at Rainbow Babies and Children's, and today she's going to share with us her research study on socioecological profiles of children with asthma in Cuyahoga County. Dr. Ronis.
Thank you very much for that. Thank you, guys. Like, eager to get going. Thank you for that introduction and the opportunity to share our work. As a health services researcher, my team and I work in the T3 to T4 end of the translational spectrum, so implementing evidence into practice and disseminating into community for population health benefit. The data that I'm going to share with you today is preliminary data from the BREATHE study, which is generously funded by the CTSC of Northern Ohio as a research program project under Module E. This funding mechanism is really exciting for us because it aims to reduce health disparities and chronic illness through the use of technology, and explicitly calls for the integration of community perspective throughout the research process. To that end, I want to make sure to acknowledge all the amazing partners and collaborators in this work from across the CTSC partner institutions, the American Lung Association, two of our large local school districts, CMSD and Cleveland Heights University Heights, as well as, importantly, parents of students with asthma. We have no disclosures. So childhood asthma is among the most common chronic conditions of childhood with substantial public health burden, really a heterogeneous collection of airway diseases involving airflow limitations and airway inflammation, impacts more than 6 million children in the United States, of whom more than half will have an attack in any given year, resulting in nearly 250,000 emergency department visits or higher levels of care, and even deaths. As a pediatric primary care physician, this is top of mind for me because it's top of mind for our families and our community. So this figure shows recent data regarding prevalence of childhood asthma among 3 to 17-year-olds. And you can see in Northeast Ohio, which is the red bar, more than double the rates of asthma in children in the state of Ohio and the US overall. And we see excess burden of asthma among children who identify as Black or Hispanic and children who are publicly insured. Chronic absenteeism is a really important marker of asthma control in children. Defined as missing more than 10% of eligible days, we know from the medical literature that children with asthma who are chronically absent have greater symptom burden overall, more often live in households, neighborhoods, and attend schools with increased levels of indoor air pollutants, and which in turn sets them up for greater risk of exacerbation that keeps them out of school. We know from the educational literature that children who are not in school, in addition to missing their academic opportunities, are missing really crucial social and emotional developmental opportunities that happen in the classroom settings. That said, historically, it's been very challenging for investigators to put together a holistic picture of this problem, in part because most of the literature that I just referenced is reliant on self-report data. So the overarching goal of the BREATHE study was to identify and test community endorsed strategies to optimize school attendance by this population, overcoming the limitations of prior work by, in the first aim, quantitating patterns in administrative data. In the second, generating that holistic understanding from semi-structured interview with parents, educators, and healthcare providers. And in the third aim, generate some pilot data what a future state might look like within a technology-informed intervention. So I'm sharing today data from the first aim. Our research question was to define which socioecological factors are associated with chronic school absenteeism among Medicaid-insured children in our community, so that highest risk group. We expected, consistent with the literature, that chronic absenteeism would be greater among children with asthma as compared to those without, and that we would see excess absenteeism among students with asthma associated with their neighborhood of residence and their school of record. To test these hypotheses, we linked individual records from 2 large data sources. The first is the child data system housed at MSES in the Center of Poverty. This data draws from 35 administrative databases. It goes back 35 plus years, and importantly includes social services, housing, and school records. And then we leveraged UH Medicaid claims for children ages 6 to 12 who had at least one Medicaid-insured encounter with university hospitals during our study period. We defined our children with asthma as having an encounter with an ICD-10 code of J45, so that asthma group plus prescription evidence for a beta agonist or inhaled corticosteroids, the medication used to treat asthma, and our comparison population had no such evidence. We used the Anderson and Day framework to help us identify which variables out of these large data sets we were going to focus on, with our key outcome being absenteeism, shown here on the right in red. So of the nearly 65,000 children who met inclusion criteria in our Medicaid claim set, we were able to successfully match nearly 2 and 3 into the child data system. In the end, we had just over 25,000 children with school records available, of whom nearly 5,000 had evidence for asthma. So our first hypothesis was that children with asthma would have poorer attendance than those without. So in this figure, the green arrow shows the desired direction. You want fewer children to miss school or more children to have adequate attendance, defined as less than 10% of days missed. In blue, we see Medicaid-insured children with asthma with adequate attendance. Gold are our UH patients without asthma, and then the red X's are the state-level estimates overall at the same time. This figure was incredibly striking to us in that while we expected some disparities and we replicated those disparities between children with and without asthma, we observed that attendance has really substantially declined over time, with fewer than half of our kids having adequate attendance in the post-pandemic years. When we looked at our data by school building, we saw high levels of heterogeneity. To illustrate, I'm going to highlight 2 school buildings of similar structure in similar locations within the county and similar levels of representation in our data set. We observed different attendance patterns between children with and without asthma, but incredibly high levels of absenteeism overall. And importantly, academic year over academic year, we did not observe consistent patterns by building. So narrowing in on students with asthma, of that 5,000 in our data set, the majority, as expected, were male, identified as Black and non-Hispanic. We saw them appear in 14 of the school districts in the county, with Cleveland Metropolitan School District accounting for more than half. Because of those high rates of chronic absenteeism, we looked at a few different ways to operationalize the outcome measure for the further analyses. And in the end, we landed on this definition where we saw chronic absenteeism in 2 or more of the 4 academic years. And just about a quarter of our students met that criteria. In terms of our demographic fixed factors, we found in unadjusted analyses that children with asthma in our data set who are persistently chronically absent were more often born to mothers of lower levels of educational attainment, were more often themselves premature. And while those who were persistently chronically absent were about 8 months on average older at first entry into our data set, we found no significant differences by sex, race, or ethnicity. In terms of potentially modifiable factors, in unadjusted analyses, we found that children who were persistently chronically absent more often had tobacco exposure documented, more often resided in neighborhoods with lower health and education opportunity, more often had a concurrent diagnosis of ADHD, anxiety, or depression, or mental behavioral health diagnosis, and had lower asthma medication ratios. So fewer achieved the quality metric of 50%, meaning that for every rescue inhaler filled, they also had a controller inhaler filled. Unfortunately, while we have information about which school buildings students are in, we don't have information about the level of support for asthma at those sites. That's a data element we're working on right now and hope to integrate in the future. Nevertheless, when we put this all together in multivariable logistic regression, accounting for demographics, we found that all else being equal, at a household level, tobacco exposure as a marker for poor home indoor air quality was associated with greater odds of chronic absenteeism. Residents in neighborhoods with higher health and education opportunities was protective. And in terms of children's health care needs, those with mental or behavioral health comorbidities had a 34% greater odds of chronic absenteeism. And while not statistically significant in the model, there's a suggestion that higher asthma medication ratios are also protective. When we conducted sensitivity analysis using generalized estimating equations to account for clustering by neighborhood and school, we found similar findings. We have a lot of limitations. So our absenteeism data doesn't tell us the reason for absence, so it could be asthma related or not. We don't have the information, as I mentioned, regarding school supports at those sites. Our preventive care, so our well child data, doesn't account for visits outside of the UH health system, so the kids could have been getting preventive care elsewhere. And our sample is blind to children who had no contact with university hospitals or who are enrolled in charter, parochial, or home schools who are not providing data to the state. That said, we've generated some really important takeaways to inform both practice and future research. For me, again, wearing my clinician hat, Medicaid insured children obtaining care at UH have incredibly high rates of chronic absenteeism, something that every clinician who works with them should know, should be asking about school attendance, absenteeism, and the reasons for that absenteeism. For children with asthma, the influences on attendance aren't limited to asthma alone, and in particular, clinicians should hone in on children who have both asthma and mental behavioral health diagnoses because they're at particularly high risk. And we're seeing some opportunities as a health system that we could intervene to reduce that risk, including increasing the proportion of children who are achieving an adequate asthma medication ratio, screening for and treating those mental and behavioral health conditions, facilitating connections to care, and supporting schools. So our next steps, we are actually next month integrating qualitative data that I have not talked about in this presentation as part of a participatory group model building activity facilitated by the Center for Community Health Integration. We'll be using that to identify action strategies to be prioritized, and that's going to inform the back half of the project where we actually get to pilot it. So thank you very much for the opportunity, and I'm happy to take any questions.
Dr. Simon.
Sarah, that was really wonderful. I have a question. You know, some of your maps look strikingly similar to Sanjay Rajagopalan's work looking at heart failure, heart attack, coronary calcium, and using a lot of very interesting geospatial modeling, 2.5 micron, ozone, tree coverage, walkability. Have you incorporated any of these measures into determining whether it's specific to neighborhoods of ozone and 2.5 micron exposure?
So while we've not included air quality data into these analyses, the proxy that we used that I blew past really fast was a measure called the Childhood Opportunity Index. This is developed out of the Ohio State University, pulling together multiple data sources to rate each census tract in terms of health and education opportunity. I'm going to forget the other two components that go into the overall measure. So we use the health and education sub-index for that, and we use the metro normed scores. So looking at the Cleveland metropolitan statistical area, how far off one direction or the other were these neighborhoods to median. It looks even worse when you look at compared to national norms.
Thank you. All right, go ahead. We'll do one more question.
Great job. Piggyback on Dan's question with Sanjay's data. So have you looked at the same zip code census tract to look at, because there are individuals living there that are on Medicaid and not Medicaid who might have asthma, obviously, to see what the factors for absenteeism then could be as you control then for that factor?
We've not looked at students without, we've not looked at patients who did not have Medicaid claims. We're relying on the Medicaid claim set. But I think that's a really important, another important limitation to this data is we're seeing sort of the tip of the iceberg in a very narrowed down specific population that doesn't represent the full breadth of asthma experience for all students.
Great, thank you.
Thank
Sarah.
you.
So